Welcome to Same Surgeon, Different Light, Season 6. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast series. My name is Sara Pereira, and together with my co-host Cherie Erkmen, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We will explore their journeys, the obstacles they've faced in their careers, and the qualities that make each cardiothoracic surgeon distinctive and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
Welcome to Same Surgeon, Different Light, Season 6. I am Dr. Sara Pereira, and together with my co-host, Dr. Cherie Erkmen, we are thrilled to be talking with our guest, Dr. Bo Yang. Today, Dr. Yang shares his remarkable career path, from medical school and early cardiothoracic surgery training in China, to earning a PhD in pharmacology in the United States, to retraining in general surgery at the University of Arizona and Stanford University. He ultimately joined the University of Michigan as a surgeon scientist. Along the way, Dr. Yang reflects on his mentors, cultural challenges, and relentless work ethic that carried him through 13 years of retraining in surgery. He also revealed his backyard hobby that keeps him balanced on the tough days. This is a compelling conversation as Dr. Yang discusses building a basic science lab while launching a complex aortic practice, developing the Y-incision aortic root enlargement technique, and learning how to become a more patient and intentional surgical educator. You know, Dr. Yang is an internationally known surgeon scientist at the University of Michigan. And Bo, we are so very grateful for your time. In introduction, the work that you have done in science and in clinical surgery is massive, and we can only cover a part of it. Dr. Bo Yang joined the Department of Cardiac Surgery at the University of Michigan in August of 2011 after completing his cardiothoracic surgery fellowship at Stanford University. His clinical expertise spans the range of complex aortic surgical procedures to the treatment of aortic pathology from the aortic root all the way to the femoral arteries, and also throughout all adult cardiac procedures for patients with complex aortic valve disease. Dr. Yang, welcome to Same Surgeon, Different Light, Season 6.
Thank you, Sara and Shui. Happy to be here.
I would like to start out with questions. So I'm really interested in your background. You studied at Xiangya University medical school, and you did training there and then transitioned to where we in the United States first met you in the University of Arizona in general surgery, and then Stanford for CT training. So this is a very unique background. Can you tell me a little bit more about, the training and the paradigm in China, and then how you transitioned to the United States?
Yeah, sure. It's very interesting. In CT surgery, we have I6 program here, not in the United States. When I was in training, in China, it's all like I6 or I5. We graduate from medical school, from high school to medical school directly. I did 7 years in medical school. Then medical school, I went to CT surgery training directly, and I only did 3 years. At that time, I really I was fascinated by what's going on in the United States. We heard a lot about the United States and the advanced advancement, the high technology. I really want to come here to learn and to study. So I came here actually as a PhD student. I was in medical school, finished medical school, but I applied for a PhD in pharmacology and toxicology. And I was lucky, and I got enrolled into the program, Tox program at the University of Arizona. And my mentor at that time was Doug Larson. This is the first important person in my life. Really helped me for my not just my PhD study, get my PhD, and also he kept me in touch of clinics. So he's a professor of pharmacology. He runs a program of perfusion program. He trained perfusionist, and he worked with Dr. Jack Copeland. The Jack Copeland is well known in heart transplant and device, and he really developed and eventually developed the total artificial heart, CardioVest. So when I was a graduate student, I went to a heart transplant conference every week, every Friday. I go there. I met Dr. Copeland very early. Doug introduced me to him. Those surgeons are my heroes, my role model. Really kept my interest in cardiac surgery. First, I was thinking, when I'm doing PhD, doing library research, which is very cool and fun, and just do research. And I found out I still have so much interest in clinical practice. I still want to be a surgeon. And after 3 years, I was finished pretty much all the studies in my PhD. So I started doing my boards, US 7 step 1, step 2, and all these things. And the Copeland really helped me, and all the other surgeons too. Other surgeons at the general surgery at the University of Arizona, they really let me shadow them and get to know me, and then they accepted me as a resident. I was so lucky. I gotta say, I was so lucky to become a general surgery resident there. Then it's I think I had a lot of help. During my PGY3, I was able to do a away rotation based on our policy. And Dr. Copeland connected me with his friend, Philip Oye at Stanford. And Bobby Robbins was the chair there. I did my elective rotation, did like 4-6 weeks there. And so I followed the Dr. Craig Miller, who became my mentor later, and the Dr. Scott Mitchell. And the whole thing just keep rolling. And I pretty much lived in the hospital. I loved it. I loved all the cardiac surgery, aortic surgery. And the funny story is because I found a room in the local lady. I stayed there just overnight, and I cannot cook or eat anything. So I was eating in the hospital. And one time I went back, he said, "Bo, where have you been? I was going to call the police office. I haven't seen you for days. I thought you're gone. You disappeared. I'm missing." I said, I lived in the hospital. So that was a great time to see all the big operations, the aortic, open heart surgery, or adult cardiac surgery, aortic surgery with Craig Miller and Scott Mitchell. So I had a blast. Then, fortunately, I've become a fellow and at Stanford, and now, and then I came in here in the University of Michigan after my fellowship. It's
a quick follow-up question to that. I mean, it's a remarkable story, but what were challenges that you had, specifically language and learning to operate in a different language, learning to, study and do research and collaborate in a second language? How did you overcome that?
Yeah, that was a barrier. Well, I remember I had my first presentation in English as physiology, and I was a first year graduate student. I had to present on a paper. I was so nervous. I was talking about things. We use projector, no PowerPoint. Project a piece of plastic paper with all the figures. I put it there. 5 minutes. I talk about that. I'm not sure anybody understood what I said. And my teacher read that needs practice. I think the PhD study helped me a lot to present, to understand the language, and able to have friends speak English. They helped me, and we as a PhD student, you present, you have your own seminar, you present all the time. So I think that's really helped me. And then go to medical, the medical field, you have to speak, all the terms, and I just keep learning, and I think the people, nurses, staff, my colleagues, they really try to understand me, and they did a good job understanding me. And I have been told I need to speak slowly, and because it's a second language, sometimes we try to cover the cover our shortcoming or weakness. We speak fast to expect that the audience would understand that that actually is not the right way to do it. The right way to do it is just speak slowly and correctly. My OR staff still tell me, Bo, you gotta speak slower.
Gosh, Dr. Yang, I've admired you so much for how you speak at national presentations, but we'll get to that. I think I tallied up that it took you 13 years from when you finished your initial CT fellowship in China to your first job in the US. And I won't ask you how old you are, but it really is a tribute to how much work it is for really talented folks like yourself to come from uh, a country outside of the US, repeat all your training in the US, and then start at your first job. So you started at your first job in 2011 and you brought your basic science lab from Stanford to the University of Michigan. And you continue to do really great science, studying the mechanisms of gene mutations using the CRISPR-Cas9 technology. And with that, we had a presentation at, I think, STS last year about the scientists that won the Nobel Prize in CRISPR technology. And these mutations cause thoracic aortic aneurysms. So really, I want to know, between all of your travel, presentations, conferences, how much time do you actually spend in the lab these days mentoring younger scientists?
Oh, that's a great question. I think for surgeons, especially cardiothoracic surgeons, to do basic science research, and it's not easy because you have two full-time job. One is, you really have to operate, make sure you are comfortable doing complex cases. You don't want to give up your clinic, because I don't, because I really like to take care of patients. And at the same time, you try to develop your lab research. In the first 5, 10 years, actually was quite difficult. And I have a lot of support from my department, and they give me, startup funding, lab space, and very two important things. I have great mentors. I have two great mentors. One is Eugene Chin, who is a vascular biologist at the University of Michigan. I met him when I interviewed here. I really enjoyed working with him. He really guided me through how to build up the lab from zero, nothing, build up. I started as a postdoc in his office, and when I started my job here, I just operating. If I'm not doing operating those kind of things, and the clinic's not that busy, I go to his lab to some stem cell research. The second one is Diana Milowitz. She was my another KO8 mentor. Both of them are my KO8 mentor. So at that time, so you really have two jobs. I remember I either doing type A dissection at night or writing grants at night. Sometimes all night through. Next day you have to meet the deadline 5 a.m. You finish it and get to my mentor, submit those things. So talking about how much time we have spent at the beginning, I have 1 day a week go to the lab, but I put my weekends there, and so I go to the lab on the weekend. My lab people say, "Oh, I'm welcome here anyway to feed the cells and doing things. You can come anytime." So we discuss research about those things. And once we build up the team after 10 years, pretty much. Now I have a team in the lab, autopilot. I still once a week in the morning, Friday. That's why today's my research day. Friday morning, I go to the lab. I talk about all the science. I run ideas, just sparkles. And I have a junior faculty assistant professor helping team, and it's really a collaborative relationship because he has so much. The technology has been advanced so quickly in basic science lab. There's a single cell sequencing. There's transcriptomics, which when I was a graduate student, I never heard of it. There was nothing there. So he's expert of this. I learned from him, and we talk together. I bring all the clinical knowledge together. So it's really great team. And then I have the medical students and postdocs will work together to guide them and teach them how to do basic science research.
How many email requests do you get every week from students around the world that want to come to your lab?
I do get quite a bit from University of Michigan and the medical students and other places. And also we have a clinical group research, which we'll have a meeting every afternoon in Friday. So I get a lot of emails that come here to both clinical research and basic science research. Yeah, now it's very hard to get people here.
It is hard.
So, I know that you received the AHA Vivian Thomas Award for investigation, and we talked a little bit about your lab, but when you started to think about the Yang aortic root enlargement, this is a paradigm shifting concept, and you're not within the security of a lab with doing work and changing things in innovation that way, but you're actually working with patients. How do you get the courage to do something different from what you've chosen? And how did it play out that it actually became a technique that you could translate and scale up to other people?
Yeah, and so I think the new ideas, new procedure develops is because we surgeons always want to do better for our patients, to give our patients better care. I still remember, when Tyron David was interviewed, how did he come up with this idea of a David procedure? He said, you look at this beautiful, perfect aortic valve, you just don't want to cut it out, replace it with prosthetic valve, and how to preserve it, then you have that idea. And then he developed this procedure, which is, everybody's learning and doing it and help a lot of patients. And I have been asked about this question, how come out this idea? I say the story is it's very interesting. It's a kind of coincidence. Also, it's always want to do something better for our patients. I had a case. So it's a lady who was about 70s, came to me with ascending aneurysm. He had AVR before bicuspid aortic valve, had a mechanical valve at 25 St. Jude. Valve works beautiful for her. She's not a problem. She had like 6 centimeter ascending aneurysm. So I came in to do the aneurysm, and I talked about, you're 75 now, you have mechanical valve. She said, if we can replace it, I don't need to take Coumadin anymore, which will be great. I said, yeah, 75, the tissue valve will last longer. So I take the mechanical valve out. I took the mechanical valve out and cleaned up everything. I sized it. The largest valve I can put in is a 23, tissue valve prosthetic valve. And people say, 23 for 75-year-old ladies, it's more than enough. But the thing is, she had a 25 worked well for her. And I just know I don't want to give her any discount. During the process, I took the mechanical valve out. I created a hole because the valve it's intraannular, right? So it's intraannular. That aortic mitral curtain at the left non-commercial, the top part was it's gone. You take it out because of the adhesion, it's just gone. So not a big deal. You just patch it. We see it all the time. We do endocarditis. So I need to patch fix it. Now I need to enlarge it. So I cut it open, so it open both directions. And I said, oh, okay. Then I patch it. Instead of close the back, I patch it up with just a little bit wider, like patch coming up. And I didn't close the back. Then I sized it. I was so easy to put a 25 in. So, oh, wow. Because, I was thinking about you give Manugan or Nix, only up to one valve sizes. But this tricked me when go both directions instead of just one cut, both directions. So I suddenly triggered this idea. I can go both directions, but how far I can go? So my practice here at the University of Michigan helped me a lot. I studied as a adult cardiac surgeon, but most time I do is type A dissections, endocarditis, root abscess. Now those cases, because I don't get referrals of nice, valve spring roots or mitral repair, those kind of cases. I want to come to the junior faculty. Only those cases, nobody wants the oncology in those cases. So that the endocarditis cases helped me. We sometimes the infection eating up all aorta mitral curtain. I saw the root. Sometimes I saw the root to the mitral annulus and the colon buttons. I say I can go as far as that to the trigons to the mitral annulus. So first case I did is August 2020, and it's a lady, small lady, had a pancreatic transplant, kidney transplant, and with severe stenosis. And annulus is very small, like 18 millimeter. Only put very small lady, put a 19 valve in. So I had that idea. I cut it open. I was going to put the size 23. I was so happy because I don't need to cut into the mitral valve to a manugan to put a 23 in. So and she back 5-year follow-up. Ejection fraction went up from 35 now normal. Gradient is very low, single digit at 5-6. Areas EOA is quite big. So I was very happy. That's how we triggered. Basically, I think it just every surgeon always trying to do better for our patients. That will trigger. There's a lot of problems that still not solved, right? And if we can find a better way to help our patients, that will improve. That will come up new ideas.
I love it. For our listeners, we're on Zoom, but we're also recording, and I see this excitement in Dr. Erkmen's face, thinking she really wishes she was a cardiac surgeon now, that she could do this root enlargement. You have to know that every resident and fellow and attending everywhere in the country, every time they stare at an aortic root now, they think yang in their head, right? So that has to be the hugest impact that you've created on our specialty. I was doing a root enlargement with a fellow on Monday, and I said, okay, should we do the Y or should we do the Nix or should we do the Menugian? And the coronaries were displaced, and we ended up upsizing her to a 25. This little tiny lady with a Y. It was pretty
That's
cool,
beautiful.
actually. So. When I looked back at the literature recently, thinking how excited I was to interview you for this, your first paper was in 2022 based on your initial experience with the Y enlargements, and it created this huge discussion at our national conferences where Bo Yang always says you can upsize every annulus by 5 sizes and that you should always put a 27 or a 29 in. And I thought of all the junior surgeons out there in practice that were still afraid to even do a Nix, right? And so, so we're trying to do a better job teaching all of the root enlargements because it's so important. And I was going to ask you if you remembered your last 21 or 23 valve you put in, but you just told us it was in 2020.
So no, a couple of things I want to clarify, Sarah. Thank you for asking this question. Number one, I do not upsize 5 valve sizes for everybody, and I can't. I just can't. I mean, I have to. This is the honest answer. So, and I do not put a 29 for everybody either. So I think most time with the trigons between left and right fibrous trigon. For men, it's about 3 centimeters. For women, it's about 2.5 centimeters. You think about for 3 centimeters, circumference diameter, you can increase about 10 millimeters because divided by pi is diameter. So the surgeon should be able to upsize 3 to 4 valve sizes if the root is not extremely small, and should be able to do that. That's what we come out. Most patients get upsized 3 to 4 valve sizes. This is number one. All right. Number two, no, not everybody gets 29. I just look at our data. No, I found out in the about 60 to 70% of patients get 29 or largest mechanical valve, which is 27, and about 20% gets about 27. About the rest gets 25. I did put a 23 valve in 2024 and 2025. The reason for that, I got the patients like 2/3 of my patients are women. It's very interesting because I mean cardiology heard they send all women to me. Women's annulus relatively smaller, and also I get Down's like Turner syndrome patients. They're very short and small. So I in the past, from August 2020 to now to December 2025, I had 6 patients. I had 23 out of 363 patients. So it's about 1 to 2%. The
That's
rest is good.
amazing.
Yeah, 25, 27, 20. I on last Christmas, I was on call. I did like a urgent operation for a very short lady from Mexico, and she does not speak any English. Her root is so small. I enlarged it. I was only be able to put a 21 mechanical valve. I've never put a 21 since this operation that started. I couldn't put a 23 mechanical valve in, but she's just so small the root. I was put able to. She was like actually pediatric patient. I put a 21 and the grading was good, but that's the smallest valve I've ever put in the sense that, but sometimes I think bottom line is the goal is with the opening of the valve, which is about 5 to 7 millimeters smaller than the label. Say 23 opening is about 16, 17 millimeter. If the patient, the native annular small patient is about 17 millimeter, 23 is absolutely enough, adequate. 19 millimeter, 25 is adequate.
But thank you. You know, I always feel so humbled because I have these cases where you're in there for a redo AVR or a redo root and you're just struggling to get a 21 even with a nix or a Y enlargement, these tiny little Turner's ladies. So now I feel so much better. Thank you.
Yeah. The key thing is we want to do this operation. We want to, put a large valve in for lifetime management. However, we have to do it safely. Make sure, get the patient through the operation. Then we look for long-term benefit.
Brings me to the next question is that you develop this technique and you perfect it, then you need to translate it to trainees. So, can you talk a little bit about your approach with trainees? And I think Dr. Pereira has brought up that some of your former trainees said that you were really tough on them in the OR, really, really tough. And tell me a little bit about education and what your expectations are and how you have evolved as an educator because you have to adhere to these quality standards, but at the same time, you have to be mindful of people and their education.
Yeah, that's absolutely right. And we need to train next generation surgeons. And my mentor Craig Miller told me, he said, "Bo, I'm not proud of you doing all the complex cases of good outcomes. I'm proud if you can teach your residents." So Craig Miller is a great teacher, great mentor, and taught so many surgeons. I heavily influenced by him. So I have very high standards for my resident fellows, and I get frustrated if they cannot get there and meet there and teach them. So I was not patient with them before. So who changed me actually is Sara Palmer. Sara Palmer is our I6 resident, and she was become my aortic fellow. So, and I'm running the aortic fellowship program, aortic program here, and each year we have 1 to 2, most of them have 1 aortic fellow. I remember, and Sara, that time I just developed this technique, and I was doing it, and I also teach her how to do other cardiac surgery, aortic surgeries. And because sometimes I get the impatient, and they don't sew as fast as I do. Of course, they're not. I'm practicing 10, 15 years, right? And those things, I get the impatient. And Sara is always, she's so resilient and calm. I remember one time I got so frustrated, but she was able to calmly that she and she's so calm. And suddenly I said, this fellow, she's a fellow. And I was getting frustrated, angry, upset, but she can stay so calm and get since case still moving forward. So that completely changed my mind. I said, God, I was a fellow, and my mentor always so patient that they come teach me. And I really need help our fellow get, but teach them. And After actually Sarah, the first one, I always say, she was like the mountain. I was like the ocean around it. They say, as hurricane, the mountain just the water's hitting on the mountain hard, but the mountain doesn't move at all. It's so calm. So after that, and I had all the fellows. I'm so proud of our aortic fellows, I6 resident. I taught these procedures. All my fellows, all my aortic fellows are able to do it. Our I6 chief resident, like Mike Pienta, he just finished his I6 training here. I taught him how to do this. He's practiced by himself. He showed me those pictures, CT scans, showed me, oh, the valve is not tilted. Looks beautiful. And so I said, yeah, no, you're doing a great job. So I am very proud of our fellows, residents, and I'm it's great joy to teach now the residents and the fellows. Also, I now understand what they need and how to teach them instead of just unrealistically expect they be as good as me immediately. That's not realistic. So we have to teach. We need to teach our second and next generation surgeons, and we have to be patient.
Yeah, I adore Dr. Palmer. I spent some time with her last week, and her stories, she promised to get me some good stories on you, but she never texted them to me, Dr. Yang. So she's now really accomplished in Minnesota. And what I do admire is that you take all of your really skilled trainees, you take them with you when you go teach the root enlargement all around the world. And that is really cool for them to feel like, wow, I'm in practice now, but my mentor is still taking me around to now teach other people now that I'm doing the job independently. So that is truly really admirable. And Sarah is awesome. So good job. I would love to ask you a question that I was thinking about. When you and I were in training, we are just a little bit older and we didn't have TAVR, right? So TAVR's evolved since we've been in practice. And now we have valve-in-valve TAVR, we have aortic root enlargements and the Yang aortic root enlargement. So if we were to fast forward 10 to 15 years from now, what do you think we'll be doing in the OR to the aortic valve?
Yeah, that's a great question. So nobody can see the future, but we can always use the history to teach us. I think when PCI started and the people everybody say coronary is going away. No cardiac surgeon. There's no future for cardiac surgeon. We're still doing so many cabbages. But it's a difference. We're doing better, right? We started with the lima now or arterial graft. Why? Because the long-term outcome is better. Patient survival is better. Same thing for this. Taiwan, PCR and the cabbages, they complementary to each other. They support each other. Some patients go PCR, some of those cabbage. It's nothing one size, one operation fits all. Same as Taiwan and Sava. They all have their indications. TAVR is great tool for patients, high-risk patients, and patients have limited life expectancy. Minimally invasive patients get better. They will help patients. That's why TAVR is so popular. SAVA, you want to go away. We just need to do better. And do better by what? We need to put the large valve in because large valve give better hemodynamics, last longer, and it's better for future valve involved TAVR. We know because the most common use of valve is 21, 23 in the past. When those patients, you have 19, 21, even 23 valve, there's no way you can do valve involved TAVR, right? So, and if you put a large valve in, create the space for the future valve involved TAVR, that's much better for long-term management and lifetime management for those AS patients. And it's very interesting. We did a study because the ROS procedure has been considered such a great operation for AS patient. They can bring the survival of AS patient to general population. So we did our study in like last 10 years based on valve sizes. Basically, we found out only in men, in aortic stenosis, male who had size 29 valve, average age is about 61, 62, 10 years survival, were able to compare to the general population, exactly overlap. So because 29 valve has a opening is 23 millimeter, and the average main annulus 23 millimeter. We have to restore the normal size of the annulus. Then they can exercise. They can live longer. That's how Ross procedures works. The boropulmonic valve, which is same size as an aortic valve, that's where they live long. They can catch up general population. So I think TAVR SAVA is not it should not compete with each other. Should support each other to different patients. We should decide SAVA or TAVR. For low risk patient, even in the medium risk patient, the young live long, I think SAVA with enlargement and the setup of future valve involved TAVR, I think that's a good lifetime management.
I agree. Thanks.
When you're, just listening to you, I can tell that you have this passion, that you have spoken on this issue and these techniques for a long time. But in this podcast, we have a chance to learn a little bit more about you, the surgeon, you, the person. And I think looking this, if you don't mind talking a little bit more about your personal life and what challenges and what triumphs you've had in parallel or integration with your successful career.
Yeah, that's one thing, and I talk about this during my professorship ceremony too. I think we surgeons and we love what we do, and we really devote ourselves to our career, patient care, research, all these things. It's very easy, we ignore our family. We took it for granted. So our spouse, our children, they are there. You don't have time with them. And when you're trying to develop your career, when you're young, anything distract you, you feel kind of frustrated, right? Oh, I have to go to another thing. The kids ask you to something. Oh, and I don't have time. You don't realize how important that is to your children and to your family. Now I realize. I regretted that, and I really didn't spend much time, and for my children and my ex-wife, and I would really make a suggestion to all the younger surgeons trying to develop their career. Do not ignore your family. Find all possible time spent with your family. I know it's very important. It's so critical. You feel this urge and trying to develop your career, trying to prove yourself. You can operate. You can do this. You can do that. You do not need to. You feel hired. You are a surgeon. You just do your best job to take care of your patients, and all the career, everything will come. And do not ignore your family. Spend time with them. It's very important.
We really appreciate that. Can you share what your favorite thing to do outside of the aortic operating room is?
I like chop wood. So as I live in the woods, I have the tree fall off. I chainsaw it. I was told don't do that. I chainsaw it to like logs. Then I carry it up here to my backyard. I chop it with axe. That's my activity. I chop them in the summer, in the fall, and I pile it up in the winter. I burn it and burn the fireplace. I love it. Burn that fireplace. You used to with my kids watch TV, with chat, those kind of things. I'm still doing that. I love it, and that's my one of my favorite things to do. It's a lot of exercise, core exercise, and also you don't need to think about anything else. I just chop chop the wood.
I wonder if the University of Michigan knows that you do this. I think they may have some input on your disability insurance.
Yeah, no.
This is the best thing we've heard, Dr. Erkmen, on Same Surgeon, Different Light in many podcasts. That Dr. Yang likes to swing an axe. My goodness. My last question to you was actually personal in that I am always so terrified of getting up to the microphone at national meetings. And when I see you, Dr. Yang, you're always sitting right at the base of the microphone. And maybe it's the axe throwing in you and the chopping of the wood, but You always are the first to stand up and you ask really good questions. You're not shy. And I would love for your advice to the introverts in our specialty of how do you do that?
Okay, so I'm nervous when speaking nationally, asking questions, especially in the early career. I'm just as everybody else, and you're nervous. You worry about people. Our colleagues, all the surgeons, the giants are sitting there just laugh at you, stupid questions, right? We all have that. So I think I got batteries because I always tell myself, number one, when I go to session, I'm interested. I'm gonna read the abstract and this I have some questions, and already in my mind. Number two, I always nowadays I tell myself, I'm here to learn. I'm here to learn. I'm here not to prove I'm stupid or I'm smart, I'm better than you, I'm worse than you. I'm here to learn. So here's my question. If I don't understand, oh, here's my opinion about this your study, right or wrong. I may be right, I may be wrong, but okay, I'm here to learn. So that's my attitude. So I'm not trying to prove myself. So I'm not nervous. So by doing that, and I'll express my ideas, my opinions. So right or wrong, as I said, you can criticize, you can say, and yeah, I'm just here to learn. So and by doing that, and I'm not nervous anymore. I'm just yeah, and it's my opinion. My colleague Shinichi Fukuhara, same thing. He's so comfortable doing that since he's always said, "Oh, am I wrong?" He's don't be afraid you're wrong. You listen things. Oh yeah, I'm wrong. I'm learning. If I'm right, okay, that's good. I can keep doing what I'm doing. So that's how I get over those things. And I don't, and I and when I think about questions, there's no stupid questions. And they just, if for younger faculty surgeons, if you have questions, and it, time is limited, yes, just go ask your question. Yeah.
Thank you. I love that. And next time I'll think of you stacking your wood so I won't be as nervous.
So we always like to conclude our podcasts with a look to the future. What do you see coming in the next 10 years for CT surgery?
Well, that's a great question. I don't think CT surgery, will go away. Everybody says, oh yeah, it's go away. It's dinosaur. No, when I would pick up the specialty, my trauma surgeon wanted me to go to trauma, vascular surgeon wanted to go to vascular surgery. I love CT surgery. I think in 10 years we will become more super specialized because and it's always a volume and outcome relationship. The more you do, the better you get. You can focus an area, and you of course you have to do general like adult cardiac surgery, but with some focus. You know, for used to be cardiothoracic peds altogether. Nobody can be accident and everything. So we'll be sub-specialized into certain area. That's number one. I think that's our specialty going to that direction. The goal is for that is provide the patient best care. Number two is I think the minimum invasive will go in that direction too. And if the minimum invasive can achieve open heart surgery, achieve that really minimize patients pain and suffering, all these things. I mean, surgery is invasive, right? We cause harm first, but because for uh, larger benefit, that's why doing surgery. If we can do it in a minimum invasive way, achieve the same thing, I think that's the best. I always know and talk about I talked to Chris Young in Australia. He's a robotic surgeon. I told Chris, I said, oh, and then Tristan Yang in Australia. I said, Tristan, if you can do AVR with the Y-incision enlargement, upsize 3-4 valve size with robotic surgery, you are gold. You're much better than me. Nobody can do that. You can do it. That'd be great. So that's another direction I think we'll go into. So that's my humble opinion.
Dr. Yang, we really appreciate all of your time, your insight, the laughs. I really admire you. You've certainly changed my career, and I'm not a junior surgeon. I've learned so much from you. So we're really grateful that you joined us today. Thank you so very much. We would also like to thank STS for your support of the Same Surgeon, Different Light podcast series. And Cherie, do you have any closing remarks for Dr. Yang?
And I think, like I said earlier, this podcast gives us a chance to learn a little bit more about you, not just the surgeon and the accomplishments, but as you pointed out, some of the regrets and the challenges, which makes us human, makes us feel like accomplishments are not inevitable. They're not just coming easy to people, but there are always challenges. And so it's really, I really appreciate you being able to share not only the successes, but also some of the challenges. Thank you very much for your time.
Thank you.
We're all human, and whatever I do it, others can do it too. So I think we'll just keep improve ourselves, provide our patients better care. And thank you for inviting me. I had a great time.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.